And again, going by the sort of the same, I'm talking about the severity of the infection. So infection severity of 3 is when, again, I've perhaps dwell on it enough about the erythema extending more than 2 centimeters. And again, I give another example. You give this to a medical student, or excuse me to say, even a child, they can straight away tell there's something wrong with that toe because of the complete discoloration of it. But I can tell you that the whole of this forefoot is very, very ischemic and infected. But the it's not as striking. So this patient had an infected ingrowing toenail. The toenail has been removed. But if the nail was on top there, I think I couldn't find a picture with the nail on top. It's just very subtle to tell that is infection. Now that the toenail, if I had covered that up, it's very difficult to tell that there's infection there. So this is again about how subtle or difficult the skin changes can make it. And to the contrary, the tissue actually does look much, much darker compared to the other foot, compared to in terms of the erythema in people with light skin. But unless a clinician or the patient is looking closely, it's very, very easy to miss it. And then the infection keeps on going on for much longer. And then the patient ends up with an amputation. So with regards to the infection point of view, the triad still plays a role. As we've talked about, the vasculopathy, the immunopathy, and the neuropathy are all playing a part. So the patients are going to have a decreased inflammatory response. That is because we still need our nerves to warn us there's a problem going on in the foot. And those messages goes down to your bone marrow to get your bone marrow to make more cells for you to fight that infection. But if those nerves are not working, then you won't get that immune response. So people with diabetes, again, so they get that diminished immune inflammatory response. So when even they do their blood test, it's not always that you see their white blood cells or what we call the CRP and the ESR, things that should go up when the patient has got an infection. You do not see those inflammatory markers going up. Likewise, if those inflammatory responses are not going up, systemically, the patient may not always have a fever. So they might have pus, like we showed you a picture of someone with infection in the heel. And they've got pus and infection in that heel, but the patient is walking on it. The patient is not developing a fever because the rest of the body cannot feel it that there is something going on in the foot because of the damage to the nerves. And again, we've talked about the decreased erythema and the decrease in pain. So all of these factors are against the patient with diabetic foot. But before the problem becomes apparent, the condition has progressed significantly. So in terms of summarizing the infection side, these are the main things to sort of bear in mind: that the decreased immune response, there's decreased systemic response, there's decreased erythema, and the pain is not a good warning sign to watch out for. So all of these are against us, and as a clinician, you will have to have, as I said, a high level of suspicion and a low threshold to action. Otherwise, people will keep losing their foot. And again, that's why the mortality is high, because these patients, by the time they get a systemic response, it's too late. And then they're dying from significant sepsis because they are presenting way too late. Again, talk a bit more about the neuropathy. Perhaps if I had brought these pictures in series, maybe this should have come first, the middle one. So this is a patient that something may look quite sort of quiescent, but actually the patient has got a nail that has gone down, the nail in the shoe, puts his foot in the shoe, and the nail has gone down the toe. But only goodness knows how long that nail has been there for. Because the patient has got no pain, the nail could have been there for weeks. But when he presents, you do an x-ray and you see that there's actually been a nail in the foot, but the patient doesn't know how long it has been there for. And of course, the patient has gone on to then lose the toe in that area. So again, the neuropathy, I mean, there's a saying that the nature's best blessing to us is pain. Because when we are in pain, we react or we respond as bad as we think that pain might be, but it's a good warning sign. And once you lose that pain sensation, that is the detriment, or one of the cardinal signs I'll say about the triad, about why the diabetic foot happens.
And, quite often I have said to family members, to people living with diabetes, do not walk barefoot. So many times. Do not walk barefoot, and people go on holiday and it's like, just fling off those shoes. But it's not safe for you to walk barefoot because, as you've so clearly shown us, the nerves can be affected by diabetes. You may not realize what is going on underneath the soles of your feet. That's just, that previous slide is just such a shocking example of that. Back to you, Chris.
And again, you only said the right thing again. And again, not to elaborate too much, but in people with sort of in Africa or sort of developing countries, yes, sometimes we're blessed with nice warm weather. And I'm sure we go to a nice warm weather, you want to be, get your feet free, walk around the beach. And I know, don't want to show lots of horrid pictures, but I've had people coming from holidays and the whole of their sole of their foot is completely degloved because they've been walking on hot sand or they've been walking on hot pavement, but they've been walking on that hot floor without feeling any pain at all. So it's worrying to know what will happen in years to come if the diabetes prevalence continues as it is and the complications continue as they are, because the weather doesn't help either. When you are in a warm climate, everything is hot. The bacteria will thrive in the heat as well. So we need to be more and more vigilant about it. This is a picture I showed at the beginning of the patients with the heel problem. And just to let you know from the angle of the patient, so this is the same patient, you can tell from the clothing, and that was the one I showed at the beginning. From the patient looking at the foot top down, could be completely oblivious about what's going on in the heel. She might maybe tell her, okay, that foot is a little bit swollen because previously it's lost a toe. And as I said, once you lose a toe, the bones do change shape. But what is going on in the heel can very, very easily be missed. Right at the beginning as well, I did talk about the other complications of diabetes, the eye problem, the kidney problem, the heart problems, and so on. So most of these patients have got poor eyesight as well. So if the diabetes has affected their eyes, diabetes has affected their nerves, they cannot see what's going on in their foot, and they cannot feel what's going on in their feet. So the tide is against people with diabetes, and as relatives or as clinicians, we will have to be their eyes, and we will have to be those that pick up these changes quite easily, early enough. But if these patients are picked early enough, it's not all doom and gloom. So these are patients with quite a severe ankle infection, going quite deep to the bone. And in most places, she will have lost her leg. But having surgery, a very, very deep, aggressive surgery to remove all the infection and the bone in the ankle, he then has a vacuum dressing or aggressive wound care with vacuum dressing to fill up. And that's the same foot there, and it heals up. So it is not all doom and gloom. If we pick up these cases early, if they are referred to the right team, the right specialist, and people receive aggressive treatment, the limb can be salvaged. And people need not lose their limbs. As we know, it's associated with significant mortality. But the main cornerstone is the need for a better recognition about what the diabetic foot is. We need to acknowledge that the diabetic foot is associated with significant morbidity and mortality. Like talk about the mobility, social life and things like that are affected, associated with other diseases and the high mortality. And the severity of the diabetic foot can be easily underestimated in patients with diabetes as well as in patients with dark skin. And the cornerstone to manage the diabetic foot is by referring to the specialist. I stand it that the diabetic foot should not be managed by just a single practitioner. It needs to be managed by a multidisciplinary team. I work in a team with a diabetologist, a nurse, a vascular surgeon, an orthopedic surgeon, an orthotics that makes shoes, and a podiatrist that debrides the wound. It needs a multi-professional to tackle it. And as I showed you one of the pictures earlier on, with early referral, aggressive and MDT sort of intervention, we can save the diabetic foot. And that is the key. If I'll summarize it as the key is early diagnosis and early referral to an MDT is the way that we're going to tackle the diabetic foot. So I know I've rushed through it, but hopefully we can have questions and discussions around it. And I can talk about it, diabetic foot, all day, but I'll end there.
That's absolutely brilliant, Chris. Absolutely brilliant. And, we don't want it to be all doom and gloom. We want to give people hope. We want to give people knowledge, and we want to empower people. So before we talk about early referral, you mentioned that we want to talk about prevention not only of these problems, but also prevention of deterioration wherever possible. So the early referral is about prevention of deterioration and prevention of those really serious and awful consequences. In terms of prevention, I would normally say to people who are living with diabetes, you need to check your feet every day. So that would be one of the tips that I would give. Any changes, anything different you notice, that is something for you to come and see your healthcare professional about. Don't worry what it looks like. You may think it's minor, but as we said, it's that sort of pyramid thing. The minor bit may be what you're seeing on the surface, but there may be a lot of stuff going on underneath. So any change you notice, that should prompt you to contact your healthcare professional about it. And don't be fobbed off. If you as a person living with diabetes is noticing a change in your one foot compared to the other, one toe compared to the other, that is something potentially serious, as we've shown, and you need to address it. You need to contact your healthcare professional. I also said about, being careful about how you care for your feet. Now, sometimes you go to see a pedicurist, somebody for a pedicure, but a pedicurist is not a podiatrist. And unless, one, if they're good, you tell them that you are living with diabetes and they take extra care. But also, if you are noticing practices that are potentially dangerous to your foot, then please don't continue to have that pedicure. And just by the same token, you don't do things, please, that are dangerous to your feet. So I see people, and I'm talking about, I don't want to call them out, some family members, and they're going at the feet with the scissors. And I'm thinking, you can't do that. I'm sure, Chris, you've had this experience. Do not go anywhere near your feet with anything sharp living with diabetes. It is so potentially dangerous. And I said before about not walking barefoot because your nerves may be affected. And I think something that we haven't yet brought up, it is so, so, so important to go for your regular checks. Part of your regular check, your at least annual check, would be a check of your feet. And please, people, do not let anybody just ask you, are your feet okay? And not look at your feet. Ideally, they should be looking at your naked feet. Socks, tights, whatever footwear you've got on should be coming off so that they and you can look at your feet and do the examinations that are needed of your feet. Sorry, Chris, you just got me spurred up with, but I think what we're trying to do is to protect people's feet, prevent those problems, prevent them being referred to your clinic, because I'm sure you don't particularly want to see them, because by the time they get to see you in a hospital setting, it's a major issue. And it's an issue that's likely to cause them major problems in their work, in their social life, in their family life. So, sorry, Chris, that was just fantastic. Is there anything else that you wanted to say before we go to questions?
I was just to say that I sort of maybe pitch this more to where the problems are, or sort of when you've got a diabetic foot problem. But you're quite right that, taking it a step down, maybe another time we can talk about foot screening and things to look out for, early signs and so on. But this was maybe a bit more to what the diabetic foot looks like, but it's really stopping people from developing the diabetic foot. It's, good diabetes control. And as you said, it's just basically when you have lost, the nerve the nerves when you've lost all those sort of early warning signs is having, that extra vigilance of letting your eyes be your nerves. And in some people, yes, their eyes are gone, then the relatives have to be their nerves, or seeing a specialist regularly. So that is the other side, sort of to get it, but from getting any tissue breakdown. But in the diabetic foot, when you've had any tissue breakdown, it doesn't matter how little, whether it's a scratch or whether it's a pinprick, is to get it seen early, like you rightly said. So I think you've summarized it enough, but hopefully this shows people that what can happen if you don't get it seen too early enough.
Yeah, absolutely. Absolutely. Because, you said it's about 2 in 100 that would have a foot ulcer in the UK. And it was about 15 in 100 for Africa, I think, from the meta-analysis. So, for the vast majority of people, this is not something that they would encounter. But we don't want that 2 in 100 or that 15 in 100 to encounter, to experience this. We want to prevent that. So we want to make that even less. That's what the aim is. Chris, absolutely fantastic. Thank you so much.
You're welcome.